I request our discussion Dr. Pandav to give his inputs for this case.
Uh, First of all, I must congratulate Manish. It's a very interesting case, and I think he was able to manage it well. I have gone through the literature and put up a couple of slides on this. Actually, that will give you a quick view of what happens in this kind of glaucoma. Can I share my list?
Yeah. Dr. Pandav, you can share your slides.
I'll just share a couple of slides on this. So this is basically, how do you go to the...
You need to go to the slideshow.
Slideshow, yeah. Okay. Yeah. So what we have is a steroid-induced glaucoma following PSTA injections, subtenons. But I think as I learned now, it was not really subtenon, it was more subconjunctival. This IOP elevation is quite common after steroid institution, whether in the form of drops or even systemic, and especially if you are giving intravitreal or a depot steroid. And mild to moderate elevation you'll find in number of these patients, probably over 50%. But it depends on most of the time the elevation may not be clinically significant, but in this case is definitely significant. The IOP tends to go along. Now, the relevant question in this case would be how long the PSTA lasts. Can we wait for this effect to go away and tide over the crisis by other means? The literature suggests that it could vary as much as 13 months, 3 to 13 months. That's the overall time period mentioned. But generally speaking, around 6 months, 6 to 9 months would be the time frame when we have to be ready to manage these patients' high intraocular pressure. Now, Manish also asked about whether the removal of PSTA will help. It will definitely, it helps. The literature support that concept, and there are some studies available where actually only removing the PSTA brought down the pressure to normal range, so it normalized the pressure. And after removing this depot steroid, the response is quite quick, and within 7 to 10 days you'll see some response, and by and large within a month or so the pressure tends to equalize, normalize. But it would also depend upon the dose and the duration for which the depot steroid was there. So if it has been there for a long time, perhaps it might take longer to normalize, and you will need therapy for a longer period of time. So how is the IOP controlled in these eyes? Most of these eyes would respond well to medical treatment, and literature suggests that 80–90% of these cases you could probably manage with the medical therapy alone, but surgery would be needed in some cases, which, like our patient which Manish presented, they could present high pressures and you would do surgery. And if they're controlled with anti-glaucoma medicines, typically it will take 6 to 9 months to medical therapy, and after that the requirement therapy tends to go down, and majority of these patients would be minimal or no anti-glaucoma therapy after 12 months of PSTA injection. So if the IOP is not too high, and if you are able to control with pressures, you can wait, and the things will be all right. And then when IOP is high, and sometimes you have to do surgery for these patients. So that would again depend on the decision for surgery, and what kind of procedure you would do would depend on level of IOP, the existing damage, and the associated conditions. So if there's a uveitis which is intractable, you'll need you would need more steroids or continuous steroid for that patient, and probably taking off steroid may not be a good option. So you would be going in terms of more aggressive therapy, which might include surgery. We have options like TRAB. Just removing the canonical depot, is one option, which helps in most of the patients. But if there is a glaucoma damage is already there, like if the disc changes have already appeared, the field changes are already there, then you probably need a lower IOP, not just to normalize the IOP. And in that situation, some filtering surgery might be required. And TRAB is a good option actually if the anterior segment is not damaged. If there are no synecdoche, then the segment is good, and the conjunctiva and the things are good. So you could probably go and do a trabeclectomy with or without removal of PSTA. And also, of course, the GDD is an option like which Manish did in these patients. Now, this is the patient actually what we have, and what we can see is a very well-defined deposteroid there. And if Manishana told me there's a subconjunctival, not subtenons, then I would say that, okay, I might be tempted to do a trabeculectomy with the removal of this deposteroid in the same sitting. And in that situation, if I want to do that, I might go for a limbal-based conjunctival flap, no, not from a conix-based, a limbal-based flaps. So make an incision, say around 8 millimeters of mercury from the limbus, and that would give you, that will allow you to remove this deposteroid as well as do trabeculectomy. So when I looked at that case, I thought maybe I might do that before I do the tube implant. The reason is that because if we remove the steroid, this is a young patient, and if we remove steroid and we have a trap which is likely to control the pressure, and the steroid effect is going to go away in 9 months time, let's say 1 year's time, and then the pressure, it might be much easier to control. Even if further control is required, even the medicines could help there. Putting a tube is a valid option, but you have a tube in the anterior chamber, and that could have long-term consequences as well. Having said that, the outcome for all these tubes and traps, you have a number of studies, TVT and other studies, which does suggest that if you have a uveitis, the trabeculectomy is not, the chance of failure more, and you have some merit in putting tube as well. So that could be a kind of a, you have
Dr. Pandav, can you sum it up?
Yeah, thank you very much.